Thank you for joining Cancer Support Community Atlanta for this Men's Urology Health Seminar, facilitated by Dr. Kristi Hebert with Georgia Urology. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to today's Men's Urology Health Seminar. I'm Katie Armsby, Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website, cscatlanta.org, to see all the free oncology support services offered virtually, which includes a monthly virtual prostate cancer support group led by a licensed mental health professional. Throughout today's presentation, we invite you to enter questions into the chat box, which Dr. Hebert will address at the end of the program. I want to welcome our presenter today, Dr. Kristi Hebert. Dr. Hebert graduated from LSU Health Sciences Center School of Medicine in Shreveport, followed by an internship in general surgery at Ochsner Clinic Foundation in New Orleans. From there, she completed a residency in urology at the Ochsner Clinic Foundation and LSU. There, she became trained to perform a wide variety of urological procedures and to treat many conditions such as kidney stones, prostate enlargement, overactive bladder, and hematuria. Dr. Hebert then chose to further specialize by completing a fellowship in genitourinary reconstructive surgery at the University of California, Irvine. Currently, Dr. Hebert works at Georgia Urology's newest location in East Cobb. All right, I'll go ahead and pass it off to you, Dr. Hebert, to begin today's presentation.
Great. Thanks, Katie. Thanks for the introduction and for putting this program together today. What we'll be talking about is enhancing cancer survivorship, not the treatment for cancer itself, but some of the side effects that come with cancer treatment, including urinary continence and erectile function. So this is the address to my East Cobb office location. Some of the things that I specialize in addition to general urology, including erectile dysfunction, penile implant surgery, and managing male incontinence. So this slide is just to depict for us the extent of pelvic cancers in the U.S. Colon and rectal cancer is the fourth most common cancer in the U.S., and 4% of all men are affected by it. Prostate cancer is the second most common non-skin cancer in men, with a great survival rate overall of 98%. Bladder cancer makes up almost 5% of all new cancers. And testis cancer, again, a great survival rate of 95%. And I bring this up to demonstrate the number of men that are being treated for these conditions, the number of men and percentage of men that are surviving these conditions. But to me, on the other side of it, that correlates to lots of men suffering with side effects from that treatment. And you can see in this graphic here how closely related all of these pelvic structures are. We have bladder here, prostate here, testis down below, and the rectum right behind, all sharing the same space in the pelvis. And so the treatment for one can affect the function of others. When you get treated for anything, one of the first things you look for are what are possible side effects. And these are just a very few number of side effects of pelvic cancer treatments. And we're going to focus today on these middle two, on erectile dysfunction and urinary incontinence. Erectile dysfunction is difficulty with either achieving or maintaining an erection that's adequate enough for penetration or for intercourse. That can range from a very mild degree to a severe degree. And it's very prevalent. So if you're looking at men above the age of 20, 1 in 5 are affected with erectile dysfunction at any point in their lifetime, cancer or no cancer treatment. And then half of men over the age of 40. So the incidence does go up with age. That totals to almost 40 million men in America that are dealing with this problem. This is a graphic depicting how erections are created. The first thing that it requires is functional nerves. So the nerves surrounding the penis become active. that allows the arteries to relax and to bring blood into them. So these two cylinders are called the corpora cavernosal bodies. They fill with blood to create an erection when those arteries expand. That expansion then compresses the veins that surround it and prevents that blood from escaping the penis, and that allows you to maintain the erection. The top 3 causes of erectile dysfunction include vascular disorders, diabetes, and medication side effects. And this 4th little piece of the pie here is pelvic surgery or trauma. So surgery for pelvic cancers is included in that category. Erectile dysfunction can also be an early warning sign of heart disease or diabetes, because these diseases affect small arteries before they affect large ones. This is a graphic depicting the lower urinary tract here. So each kidney has a ureter that drains the urine and plugs into the bladder, one on each side. The bladder then squeezes to empty the urine, and that urine goes through the prostate and out of the urethra. When you have prostate cancer surgery, the prostate is removed by making a cut at the top of the prostate where it meets the bladder, and a cut at the bottom where it meets the urethra or the external urethral sphincter. And that intermediate segment is removed, and the bladder is then plugged in back to the urethra with sutures. And you can see here what's called the neurovascular bundle. So the nerves that control erections is sitting on the bottom of each side of your prostate, and they have to be peeled away from the prostate and protected during the surgery, and that's called a nerve-sparing prostatectomy. But even so, if you do the most nerve-sparing procedure that you can possibly do, erectile dysfunction can happen in either a temporary or a permanent manner. About 1 year after prostate removal surgery or prostatectomy, whether done in an open fashion or a robotic fashion, some studies vary, but roughly between 10 and 45% of men still struggle with erectile function. Radiation for the prostate, unfortunately, doesn't get away without that side effect either. It affects up to 50% of men with their erections after radiation. The difference we typically see with surgery versus radiation is that with surgery, it's more of an immediate effect that you notice, and with radiation, it tends to be in a more delayed fashion. Regardless of the problem, the cause, or the source of erectile dysfunction, we generally have the same treatment options that we present, including oral medications, injection therapy, implant surgery, vacuum device, and urethral suppository. And I'll talk a little bit about each one of these options. Oral medications target blood flow. So we just mentioned earlier how erections are created and the blood flow that it requires to enter and stay within the penis. These medicines focus on that process. You usually take it an hour in advance of anticipated sexual activity, and it's not going to create an automatic erection. It still requires sexual stimulation in order to initiate that blood flow increase. It typically will last in your system for up to 4 hours, although one of our options, Cialis, also called tadalafil, can last up to 36 hours in your system. You can only take one a day, and you want to take it on an empty stomach because you'll absorb more of the medication. Heavy meals, especially fatty meals, will decrease the amount of the medication that makes it into your system. They're effective in about 50 to 85% of men. On average, we give it a rough estimate of about 60%. But if you look at men with ED after having prostate surgery, almost half of men who initially start these medications end up stopping them for one reason or another. And men with diabetes tend to have a little bit more resistant erectile dysfunction. So medications might not do the trick for men with diabetes. We typically have to move on to other options that are a little bit more invasive. The most common side effects of these pills can include headache, facial flushing, stuffy nose, and upset stomach. The reason being it causes an increase in blood flow not only to the penis, but to other areas of your body. So that blood flow to your head can give you a headache, can make your face red and warm, and can cause you to have the sensation of a stuffy nose. Before taking these medications, though, you want to talk to your doctor to make sure that your cardiovascular status can tolerate sexual activity. If you're on alpha blocker therapy, you probably shouldn't take those doses at the same time of day. Alpha blocker is the medication that we have patients on for enlarged prostate. So medications like Flomax or tamsulosin, doxazocin, alphazocin, they're all in this category. You can't take it in combination with nitrates. So nitroglycerin for chest pain, for example, you can't take them within 24 hours of one another. So if you're taking nitroglycerin or you carry it in your pocket, these pills probably aren't the best option for you. And then always talk to your doctor if you have heart problems, stroke, or alterations in your blood pressure. The reason that all of these medication interactions happen is because Viagra, Cialis, Levitra, they can all lower your blood pressure. So if you're already taking the medication that can do that, you don't want to take them at the same time for sure. And some of these, you can't take them at all together within the same day. Moving on to the vacuum erection device. So what it is a plastic tube or cylinder that you place over the penis. There's a pump, either hand operated or battery operated, that creates a vacuum seal, draws blood into the penis. You take that cylinder off and then you place an elastic ring at the base of the penis to hold the blood there. So the tube itself creates the erection and the ring maintains the erection. Satisfaction rates vary, although pretty good, 65 to 80%. Despite that success rate, most patients actually move on to other aids for various reasons. Vacuum device tends to not be a long-term option for lots of people. And some of those side effects include blocked ejaculation. So if you have a ring on, you're probably not going to ejaculate fluid in the same way. It creates some bruising of the penis. This is more important for patients that are on blood thinning medications. Discomfort and penile numbness or coldness from keeping the ring on. The most common reasons for discontinuing it though is because the erections are insufficient, difficult mechanics or cumbersome to work with, the bruising, and the lack of spontaneity. Although if you think about lots of these options, including the pills, it's a little bit less spontaneous because you have to anticipate and take it ahead of time. Urethral suppositories. So it is a medication that's administered directly into the urethra. So it comes with an applicator. You insert it into the urethra, and this is always under doctor's supervision for the first time so that we can make sure you're doing it correctly without damaging anything. You drop the suppository in the urethra and then give it about 5 or 10 minutes to absorb. And the effectiveness is about 40 to 65%. About half of men don't continue using it on a long-term basis. It also has to be refrigerated, and so that can limit travel to a certain degree. Side effects can be pain from insertion, so a burning sensation. It can cause a little bit of blood at the tip of the penis or in the urine. Low blood pressure and dizziness, although those are less common side effects. The most common reasons for stopping it for men that do stop it is that it's inadequate erections or the pain sensation from inserting it, that burning feeling. Penile injection therapy. So this is a self-injected liquid medication that we inject with a very small needle, like an insulin needle or a TB syringe, directly into the penile bodies itself. Those bodies that contain the arteries with the blood flow, we inject it directly into there. Again, first time always under a doctor's supervision so we can make sure you're doing it correctly. You never want to inject at the top of the penis. That's where all the nerves and arteries are. And you never want to inject on the bottom side where the urethra is, because that can affect your urination. We always teach you to inject it directly on the side, either the right or left side. The onset is pretty quick, within 5 or 10 minutes in most people, sometimes up to 20 minutes to have its full effect. 60% of patients were satisfied and continue use, although some studies suggest that number can be up to 90%. Long term, though, only 20% continue the therapy. Long term being defined as years. Most common side effects is pain from the injection, scar tissue created if you're injected at the same place each time. You can get a little hematoma under the skin from the injection, which is very minor. Most common reasons for discontinuing this therapy is insufficient erections, pain from the medication itself, or a general dislike of injecting or dislike of needles. Alprostadil is one of the potential medications that we can use. We do have combination injections as well. It's called bimix or trimix, where 2 or 3 medications are mixed together that tend to have stronger erections or more effective and can decrease the pain sensation caused by some of the medication. And then we'll move on to talk about the penile implant. So this is a surgical implant that's entirely contained in the body. No one would know you had it unless you told them. It contains different components, a pair of cylinders, so 2 cylinders that go inside of the body of the penis. There's a pump that we insert inside the scrotum next to a testicle, either the left or the right side, and then a reservoir that contains saline, and that reservoir is implanted inside of the abdomen next to the bladder. So this is never seen or felt typically. So in order to function it, you squeeze the pump that's next to the testicle. That transfers the fluid from this reservoir into the cylinders, and those cylinders become erect and firm. And then when you're finished, you deflate, which is a button on that pump, again inside the scrotum, that transfers the fluid out of that cylinder and back into the reservoir. 98% satisfaction rate, describing their erections to be excellent or satisfactory. And it can have a pretty lasting effect. These devices can last for many years. In fact, at 7 years, over 90% are still in use and haven't had to have any revision surgery or removal. Every surgery and every device comes with its own risks. And so it's really important to know that after you have this device, having a natural or spontaneous erection will be impossible, either on your own or with any other treatments that we previously discussed. These cylinders are implanted inside of those erectile bodies, and so it destroys that tissue. So I tend to think of this as kind of a last resort option for when the other options either don't work or are not satisfactory to any degree to patients. It's a mechanical device, so it can it can fail and require revision or removal. Some of those failures can be due to a leak, so the saline leaks out of the system, which causes no harm to your body, but can make that device no longer effective. The pump can fail to where it's sticky and doesn't inflate anymore. And the opposite can happen. It can create auto-inflation, which means that it inflates due to a malfunction when you don't want it to inflate. And that's a much more rare occurrence now, as this device has been revised and improved over the years. That's less of a risk to happen. Of course, pain, generally in the immediate postoperative period. It's very rare to have long-term pain from the device. And infection. So if this gets infected, it has to be removed. Possibly replaced, but always removed. And you're at a higher risk for that if you have diabetes, spinal cord injuries, or any open sores or wounds in your body. Medicare and most private insurance companies do cover this, although your plan may vary, so you want to check with your insurance provider. And this is an example of the device outside of the body. So these are the two cylinders that get implanted inside of the penis, the pump that goes next to the testicle, and the reservoir that holds the fluid inside of your abdomen. So now we'll move on to discuss urinary incontinence. And we'll focus on stress incontinence because there are different types of urinary incontinence, but this is the one that we most commonly see after cancer treatment. The urinary sphincter muscle is what you squeeze to control or to cut off your urination. And that muscle is damaged or weakened, so you can't squeeze or stop the urine from flowing when you cause physical stress. So laughing, lifting, walking, bending, pushing, pulling, anything that causes you to strain or causes impact will cause leakage. That's stress incontinence. After prostate cancer surgery, a large majority of men will suffer from this. Almost all of them immediately, and even a significant percentage of them long-term after surgery. And that's 500,000 men worldwide at any given time. So back to a description of urination. The bladder squeezes, the urine pushes past the prostate, or if you don't have one, pushes it into the urethra. The external sphincter muscle surrounds the urethra, and that's what you squeeze to stop the urination. And then the urethra, which carries the urine outside of the body. That sphincter muscle is what gets damaged or weakened with either radiation or prostate cancer surgery. Other causes include neurologic diseases, enlarged prostate surgery or BPH surgery, external beam radiation, or the seeds. So brachytherapy also can cause this as a side effect. It occurs in about 2% of men after treatment, so a little bit less incontinence after radiation than after prostate cancer surgery. And then pelvic trauma can cause it as well. So back to talking about how prevalent prostate cancer is. We talked about it being the second most common non-skin cancer, but what that equates to is 180,000 men diagnosed with it each year in the US. Not everyone gets treatment right away, depends on your varying degrees of cancer, but about 70,000 prostatectomies are performed each year for prostate cancer. Most heal within the first few weeks to months after surgery as far as incontinence is concerned, but after 1 year after surgery, 9 to 16% of men may still have persistent leakage. These are a few short-term treatment options. I say short-term because most people tend to move on to different options after going through these. So behavioral modifications, controlling the amount of fluid that you take in, planned restroom breaks, also called timed voiding. The more frequently you empty your bladder, the less urine that will be in there to leak. Now, to a certain degree, that can become excessive as far as frequency, but about every 2 hours is considered reasonable to try and decrease the leakage that you experience. Pelvic floor physical therapy or Kegel exercises to strengthen that muscle. Biofeedback, also in the same category. And then trying to cope with the leakage instead of correcting it. So pads, diapers, catheters. We don't recommend internal catheters like a Foley catheter for incontinence because catheters come with their own potential risks, including infection. And penile clamps. So this is an example of one here. This is an external device that has a cushioned part on the inside. You place it over the penis, you tighten the clamp, and then you release it several times a day when you need to urinate. Now, more long-term treatment options, also more invasive. We have the male sling and the artificial urinary sphincter as the two leading options. The sling is designed to support the urethra and support that sphincter muscle to better control the urine. It's more appropriate for patients with mild or moderate stress incontinence. So up to 3 pads per day is probably the highest amount of leakage that we would want you to have in order to consider the sling. Anything more than that, it probably is not going to leave you in a very satisfactory situation. It's made of a soft mesh material. Again, it's completely concealed inside of the body. The artificial urinary sphincter, on the other hand, is designed to replicate the external sphincter muscle. It surrounds the urethra and compresses it and prevents the exit of urine. It's meant for all levels of stress incontinence. So someone with severe leakage or more than 3 pads per day, this is the option that's probably going to best benefit you. The device itself is made of 3 small components. There's a cuff that surrounds the urethra. There's a pump, again, implanted next to a testicle inside of the scrotum. And there's a balloon that stores fluid inside of the abdomen or the pelvis area. Let's focus on the male sling for now. So it's minimally invasive. Normal activities can be resumed 1 to 2 weeks after the procedure, although I put restrictions for about 4 weeks after the procedure. The reason being, this mesh is implanted internally, and its function and efficacy completely relies on it staying in place where we put it. And so if you do too much activity too soon, that sling can loosen itself and be less effective. Some benefits are that it doesn't require any interaction or any function or any moving parts. So the complication risk is much lower. The artificial urinary sphincter, again, those 3 parts that we talked about, the cuff that surrounds the urethra and compresses it, the pump, and then the balloon that stores the saline. It mimics your natural urinary sphincter. It does require you to squeeze the pump in order to urinate. So without squeezing it, that cuff will remain compressed against your urethra and you will not be able to urinate very easily. You would be straining and pushing very hard to get the urine out. When you squeeze the pump, it transfers the fluid out of the cuff back to the balloon. That gives you about 90 seconds or so to empty your bladder. And then it automatically reinflates to keep you in that closed position. Risks of the sling. So number 1 is device failure. So persistent incontinence despite having the sling in place. Urinary retention, although that risk is very low, less than 5%. Postoperative pain or discomfort. Irritation of the wound site, foreign body response to the mesh. But these are much lower risk compared to the sphincter. The sphincter can malfunction or fail. It can require revision surgery or removal. Infection, which would require it to be removed. The cuff that's constantly compressing the urethra can cause the urethra underneath to be damaged or to create a hole inside of the urethra. The device would have to be removed in that case and the urethra allowed to heal. So in summary, erectile dysfunction and incontinence are frequently seen side effects of all pelvic cancer therapy. And the treatment options depend on what kind of cancer treatment you received, your degree of disability or bother with your symptoms, and your overall health condition. So please don't struggle in silence. Discuss these with us. We have options to help you. So what I'll do now is answer a couple of questions that were sent in ahead of time from some of you. One gentleman asked, Are there exercises for reestablishing greater control of urine flow? And the answer is yes. That pelvic floor therapy or Kegel exercises that I mentioned a few slides ago, right here. So what this does is tries to rehabilitate or strengthen that muscle in a natural way. And to do this, you squeeze your muscles, and it's important to squeeze the right one. So you're not going to tighten your buttocks or your abdomen. It's that internal muscle that you squeeze up and in. It's that same muscle that you squeeze in order to stop your urine flow or to prevent the passage of gas, those pelvic muscles that you tighten. And to practice those exercises, you want to tighten that muscle for about 5 seconds and release it for 5 seconds. And you do that repetitively at least 5 times in a row and at least 3 times a day. And as you get good at it, you want to increase until you're doing it 15 times in a row, holding it for 5 seconds and releasing it. It's also that same muscle, you'll know you're doing it right when sometimes the penis will move up and down as you're doing it. So that's very effective for strengthening the muscle, but you have to be very patient because it's not going to give you an effect the next day or the next week. It's just like any muscle that you work out, the effects and the strength of it is only noticed weeks later, up to 3 months later for its strongest effect. And if you stop practicing it and stop doing the exercise, that muscle will get back to weak. And so you have to maintain it every day. The good thing about it is you can do it in the car when you're driving. You can do it when you're sitting watching TV at every commercial break. So it's something that has to be a habit for you in order to reap the benefits. The second question we received, it's been 7 months since undergoing a radical prostatectomy. My erection is about 80%. Is that something that can be improved? I also experience urine leakage during orgasm. Will this improve over time? So the answer to number 1 is yes. So that erection can be improved after prostatectomy. But generally, once you get to about 1 year after surgery, after you give those nerves as much time to recover as is reasonable, generally at about a year, that's when we stop seeing any further improvements. Although some people can keep improving up to 2 years, most reach their maximum at about a year. And so any of those treatment options that we discussed, I would experiment with those over the first year. And after a year, if they're still not effective or not reaching your satisfaction for whatever reason, then you can consider the implant or the surgery. As far as urinating during orgasm, that is a very common symptom after prostate surgery removal. That's considered incontinence or stress, a form of stress incontinence. And so the treatment options are going to be very similar, although a clamp is probably not practical. Diapers, catheters, probably not practical either. You would probably want to consider, if it's bothering you or creating a problem in your intimate life, you'd probably want to consider a sling or a sphincter insertion. Follow up to that question. I'm taking 5 milligrams of tadalafil or Cialis every day. Should I start tapering off, and will it affect my erection? The answer is we don't know. So most patients after prostate cancer or prostate removal surgery are placed on a penile rehabilitation program where you're given a daily Cialis or Viagra to take to try and increase blood flow, either on demand or every single day, even if you're not sexually active, to try and see if increasing blood flow to that area will result in a faster return of erections or a more lasting return of erections long term. And the jury's still out on that. We don't know the answer. There's conflicting results on studies that have been done, although we certainly haven't proven any harm to it. And so we really encourage this Whether or not that continues for 18 months, it's going to be up to you. There is potential for that to be helping you, but we really don't know the answer to that yet. So that's, sorry, I don't have an answer to pin down for you. One final question is, it's been a while since I've been able to achieve an erection. Can using a vacuum pump device be used for rehabilitation purposes? And the answer is yes. So the vacuum device and pills like Viagra and Cialis and Levitra can be used during that rehab process. Can a vacuum device be used in combination with an oral medication such as Viagra? And the answer to that is yes as well. So those are the questions that we received ahead of time. Katie, do we have any additional questions on the chat box?
We do. We have a question. Can you discuss briefly Peyronie's disease?
Yes. So Peyronie's disease is a form of erectile dysfunction in the sense that it's curvature of the penis, an abnormal curvature. And it's something that we see develop suddenly in men. Sometimes there's a trigger, such as a traumatic event during sexual activity, and sometimes there's not. And the only thing we can associate it with is microtraumas. So microscopic damage on that level during surgery, during sexual activity, that can be additive and create a plaque, which is a calcified or a scarred area in that casing surrounding the erectile bodies. And that area doesn't expand when you have an erection. And so that causes one side to be shorter than the other because it's not expanding, and that creates the curvature. The treatment options that we have for it depend on which phase you're in. So there's an acute phase, which is while changes are still happening. So the curve can get a little worse or can go in a different direction. And then there's the stable phase when there's been no change in that curvature for a 6-month period. And that's very important because one of the options for correcting that curvature is going to be surgery. Another option is going to be injection therapy. And it's much better to do it once you're in a stable phase because you don't want a moving target. If you're having surgery and we create a straight erection for you again, but you're still in that changing process and you develop a further curve after surgery, then there's been no good that's done for you. But when you're in the stable phase, the injection therapy called Xiaflex or the surgery can create a very straight erection and restore your sexual life if the curve was causing a disability.
Okay, thank you, Dr. Hebert. And a question that did come up in the chat box: how long after prostate cancer treatment would you wait before treating someone with a sling or sphincter for incontinence?
Good question. I would wait about a year. The reason being the rehabilitation process, the Kegel exercises, the physical therapy can restore that continence for you without requiring surgery. In fact, the majority of patients do regain their continence. And so we don't want to jump too soon and do something for you that, we wouldn't necessarily need to do if we were a little bit more patient. Now, there's some exceptions to that. Let's say someone has severe incontinence and they're going through all the therapy and the treatments and they're not seeing any improvement and they're at 9 months and they've been 6 months at the same stagnant severe leakage rate, then that may be something to consider a little bit sooner than 1 year. On the same token, after a year, the continence generally doesn't continue to improve. You generally will have gotten the benefit that you're going to get. And so 1 year tends to be a good mark for that.
Okay, and would the response be the same for erectile dysfunction?
Yes. I would say the answer is the same for erectile dysfunction when it comes to the surgery. But all the other options we can do at any point in the recovery process.
Okay, thank you. And another question, how long after prostate cancer treatment would you wait before recommending someone consider a penile implant?
So that's about a year as well, to make sure that you've reached the maximum amount of recovery you can reach on your own.
Okay, thank you. And I think this is something you had touched on earlier in the conversation. Does having a penile implant alter or change how you urinate?
It does not. So it will not affect urination at all, but it will affect erections. One thing I didn't discuss is that when you inflate the cylinders, it's not going to give you the same firm rigidity as a natural erection did when you were 20 years old. And it's also not going to give you the same expansion or length that a natural erection would have given you at 20 years old. So there is a compromise there in the firmness and the length. But that's overcome by the fact that if you're at the point considering the implant, you've probably gone through all the other options. And so you're not going to get an erection like you were when you were 20 years old. And the other benefit of it is you can use it as long as you would like. You inflate it, you can use it for 2 hours if you'd like, 3 hours, and deflate it when you're finished. So the downsides are a little bit balanced by the good sides of it.
Okay, and I think the last question as we're wrapping up, can you have both an implant for incontinence and also an implant for erectile dysfunction?
Yes, you can. Again, another reason to wait the 1-year mark to see where you land on both of those symptoms, because you can have both implants and you can have them implanted at the same time. In fact, it's better to have them implanted at the same time rather than having one surgery and then coming back for another one, because they're implanted in a very similar area. And you don't want to go back if you can avoid it, because you can potentially damage the one that you had first while you're trying to implant the second one. Although we do it that way often for various reasons. You can have both at the same time. You have a pump on one side of the testicle for the implant, for the penile implant, and one pump on the other side for the artificial sphincter.
And in closing, I do just want to remind everyone that tomorrow we'll be hosting a program with Shritika Eula, certified genetic counselor with Northside Hospital Cancer Institute, that's focusing on men's hereditary cancer syndromes. For more information on that program or any of the other virtual oncology support services offered, including a monthly prostate cancer support group, please visit our website, cscatlanta.org. And as we wrap up, Dr. Hebert, I want to thank you for sharing your time and expertise on this program. And do you have any closing remarks you'd like to share?
That's all I've got. Thank you, Katie, very much for arranging this and for being here tonight. And thanks to everybody who showed up to hear a little bit about ED and incontinence.
All right. Well, thank you again, Dr. Hebert. And thank you, everyone, for joining us. We hope to see you again soon. Take care. Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.